take-home message for you guys. Okay? So let me think. So yeah, you can get other metabolic abnormalities like hyperglycemia, you can get hyperuricemia and gout, you can get hypokalemia, especially for those patients with some unrecognized primary hyperaldo. You can become more hypokalemic if you start a thiazide. But always think about the possibility of your patients having that. If you see a patient with hypokalemia and hypertension, always think about primary hyperaldo. I actually have a clinical case later.
Why can you do like furosemide?
Furosemide is actually a very weak antihypertensive agent. We always use it in advanced kidney disease and heart disease because it helps with sodium excretion, and it also helps with potassium excretion for those suffering from kidney disease, limiting the use of these other medications. But in hypertension medicine, we never use loop diuretics as sole antihypertensive agents. You're only going to see it for those patients that are actually like thirst pacing, or they actually have one of the ones that I mentioned, heart or kidney disease. Another consideration is the thiazides are very ineffective when the GFR is less than 30. So when you're reaching those stages of stage 4 kidney disease, that's when you start thinking about, you know what, we need to get rid of this. Let me probably put this patient on something else, like a long-acting calcium channel blocker. But this stepwise approach is almost guaranteed to control almost 100% of your patients. What I would suggest is that the way I do it in my clinical practice is that I prescribe. I bring the patients in about a week or two. Personally, I like 2 weeks because you guys know from pharmacology that you need five half-lives to be able to reach a full therapeutic effect. So that's what I normally do. And you always prescribe medicines in addition to a good exercise regimen, weight loss recommendations, and dietary sodium restriction. And when you bring the patient, before you add another agent, make sure you maximize the one that you're already given. So that's how I do it, because more medications represent more cost. Patients will get burned out. Just imagine taking multiple medications. They all have side effects. We all know that. And it's not easy to ask your patients to commit to another medicine for the rest of your life. Just think about like if you were the patient, like put yourself in their shoes. Like, do I want to? Is that a cricket or a cockroach?
It's a cricket.
Okay, it's cute. So if you're actually committing your patients to a lifelong therapy, teach them, negotiate with them, tell them, you know what, it's possible that I can get rid of this medicine if you're able to do this and this and this, because that you're empowering your patients to learn about the disease and to do things to improve themselves. But when you're not a good clinician, you just prescribe, come back, let me give you another one. Good luck trying to take all these medications. It's always my take-home message. Communicate with your patients and educate them the reason why you're doing what you're doing. Always is extremely important to do that in clinical practice. Okay, so have you guys heard about renal denervation? So this was like very promising therapy because we know that patients with excessive sympathetic response, they're associated with paroxysmal hypertension. Like there is even a syndrome called pseudo Pheochromocytoma. Those patients resemble the biochemical syndrome without having the biochemical excess. And it's all like sympathetic system mediated, like patients that go from 0 to 200 within minutes. Those patients, it was very promising because they say, like, you know what, we're going to cure hypertension. We're just going to go after the sympathetic plexus. We're going to do an ablation, and these patients are going to have we're going to surgically cure hypertension. You know, unfortunately, there is no data so far. They're doing like a follow-up study on the Simplicity studies. They're actually now like Simplicity 4, I think was like the last thing I looked. There was no evidence that so far we have a renal denervation procedure that is FDA approved or successfully demonstrated in clinical studies that is approved for hypertension management. So I don't think you're going to get that on your reports. I don't think you're going to be asked, but I want you guys to know that. Okay? Okay. So the correct answer is spironolactone. Okay? So every time you change the dose, you need to do labs. Always remember that. You don't just go up to 50 milligrams and I'll see you back in 6 months. No, every single time you need to assess potassium. Okay. Okay, so this is a little workflow. Eliminate pseudo resistance. We talk about it. Identify common non-endocrine causes of resistant hypertension, and then you evaluate patients for endocrine causes of secondary hypertension, either because they have specific signs or symptoms, or because you ended up finding an incidentaloma. On your boards, you never answer adrenal imaging unless you have biochemical evidence. I'm gonna go over that. Do not answer, I'm gonna do an MRI of the adrenal glands to find out why this guy has so much hypertension. That's always the wrong answer, always. Because then you have an incidentaloma and you don't know what to do with that. Okay, so these are the endocrine causes, the more common causes, the primary aldosteronism, primary hyperaldo or Con syndrome. So most of the patients, they have hypokalemia, but not all of the patients, but they tend to have potassiums in the low normal range. The other thing that's interesting when you pay attention to the labs, they almost look like if they're taking a diuretic. The bicarb is high and the potassium is a little bit in the low side, and they have hypertension. So when you see that, you think about primary hyperaldo.
Question. Are
Yes.
the patients also on chronic steroids? So which one?
It's
how do you
difficult
rule
to
out,
it's difficult to differentiate, to rule out like Cushing's.
How do you rule out Cushing versus?
There's no way of doing it. You need to do like a 24-hour aldosterone. 24-hour cortisol. But the patient already on steroids, there's no way of like ruling it out unless you stop the steroids. But that's what we call like a medication-induced Cushing. If you have a hypertension, hyperglycemia, you're giving too much steroids. So the question you need to ask yourself is like, do I really need to give these patients this much steroids? Because most doctors, rheumatologists, nephrologists, and pulmonologists, we're trained to stay away from steroids unless they're absolutely necessary, because they have significant side effects. Yeah, so Pheo, you look for the spells, palpitations, diaphoresis, headaches, tremors, pallor. You look for those familial syndromes, MEN1 and MEN2. Hypertension with anesthesia, that's a vignette that they give you on the boards. Young onset. My co-fellow, when we were doing our transplant rotation at UCLA, she was having a lot of these symptoms and she self-diagnosed with Pheochromocytoma. And I told you guys that I've only seen 2 cases. That was one of them, and the other one was in my practice. I've never seen Pheo, so it was actually pretty cool that she found that out by herself. It wasn't cool for me because I needed to do a lot of extra call for her. But anyway, so part of the workup of a patient with the idiopathic cardiomyopathy is to rule out Pheochromocytoma. Okay, so Cushing syndrome. Patients complain of muscle weakness, glucose intolerance, Cushingnoid appearance. And most patients with spells do not have Pheo. Pheo is not common. It's common in your boards only. Okay, can you help me read the second question?
37-year-old white female referred to you for resistant hypertension. Occasional headaches, fatigue, and muscle cramps. BP is 170/100, BMI is 27, exam is otherwise unremarkable. Enalapril twice a day, hydrochlorothiazide and triamterene 25 and 37.5 q day, atenolol 50 q day, potassium is 2.6. The other labs are normal. Which of the following would most likely establish the correct diagnosis? Fractionated plasma metanephrines, renal angiogram, plasma ratio of aldosterone to plasma renin
Activity.
Low dose dexamethasone suppression test, 24-hour urine aldosterone after oral sodium loading, and TSH.
That's a hard question to answer, but try your best. So, take home message. If you see a potassium of 2.6, that's very abnormal. I'm not talking about like people are gonna die or everything like that, but that shouldn't be. That's what I'm trying to say. The kidney, the potassium homeostasis happens in a very efficient way in the kidneys. In other words, the kidneys will make sure that you retain potassium or you excrete potassium if you have a healthy kidney. If you have 2.6, it's almost guaranteed that you have some sort of unilateral corticoid excess syndrome. You need to investigate that. So this is what we're going to talk about. We're going to talk about primary hyperaldo. So what do you think?
C?
C is the screening test, but that's...
Oh, to establish?
You need to establish the diagnosis. Will be like a 24-hour year in aldosterone. I want to work you through the workflow. But that's another thing, tip on your boards. You need to understand what they're asking you. Sometimes we think like, oh, we got it correctly. Sometimes they ask you, what is the most important next step in the management? And you totally get it wrong. It happened to me many times when I was preparing for my board. So try to read always, what is it that you're asking me twice? The way I did it is by learning it up front. Okay, I want to see what they're asking me, and then I read the whole question, I read again what they're asking me. So that way I know what I'm dealing with. Okay, so the true prevalence is unclear because a lot of these patients, they go unrecognized. And sometimes these patients, they have like premature complications from hypertension. They either have strokes, hypertensive heart disease, hypertensive kidney disease, and they go unrecognized until somebody gives them a spironolactone because they want to manage secondary hypertension, and that's the end of the story. Or because somebody does the whole workup and you find out that this patient truly had mineralocorticoid excess. But as you can see, the prevalence of primary hyperaldo and resistant hypertension can be as high as 23%. So it's pretty high. So basically, this is how you think about it. You think about possible PA, and then you do the screening test, which is the aldosterone over plasma renin activity. The way you're always going to remember it, just think about like R. That's how I memorized it when I was a fellow. R. Aldosterone in the numerator and plasma renin activity in the denominator. So if your test is suggestive for probable PA, and it's suggestive when your aldosterone level is greater than 15, or your aldosterone over plasma renin activity is greater than 20, then that's when you do a confirmatory test. And the confirmatory test is done by doing a 24-hour urine aldosterone. I'm going to show you how we do that. Okay? So there are a lot of problems with this test, and that's why we only use it as a screening test, and the information we use it like with a grain of salt, because many factors can influence one way or the other, like timing of the test, the diet. Typically we recommend that the patients have a lot of sodium when you're going to do this test, but is that a feasible recommendation with somebody with severe hypertension? Probably not, right? So position, supposedly like there's a lot of changes, orthostatic changes associated with the aldosterone and plasma renin activity. And some labs, they require like special handling and mismanagement of the sample. And in the real world, this is never convenient. So basically, believe it or not, the Endocrine Society is the one issuing guidelines for this. But in real life, you guys, as internal medicine doctors or the nephrologists, not even the cardiologists, the nephrologists are mostly doing the diagnosis and management of these patients. But I want you guys to think about primary hyperaldo, either if the plasma aldosterone is high, greater than 15, or if the ratio is greater than 20. The higher, the more likely that you're dealing with the real deal. Okay? These are just examples in how a medication can actually influence the renin or the aldosterone one way or the other. So it becomes overwhelming because the recommendation says that you're going to stop beta blockers, diuretics, ACE inhibitors, calcium channel blockers, and you're going to end up putting your patients on hydralazine, on alpha-methyl dopa, verapamil, terazosin. And the reality is like, who's going to do that? No one is going to do that. That's why I disagree with this guideline. And what I really try to do is before I start an ACE inhibitor or aldosterone blockade, I check the ratio. If the ratio is high, then I go and I get the 24-hour urine aldosterone. So this is an example, like for instance, like just to show you how the test can be very misleading from the denominator dependence on the plasma renin activity. If you have a patient with like aldosterone, no medication, aldosterone of 16, that's abnormal, right? I told you guys that greater than 15, you start thinking, but you gave a beta blocker and you suppress the renin, and then it's gonna give you a ratio of 8. This is a false negative. So you're gonna be like, okay, this patient doesn't have it, but you didn't do a good job because you were supposed to stop the beta blocker. So it's a little confusing. My advice to you is look at the whole context. If you feel strong that this patient may have it, go straight to the 24-hour, to a 24-hour urine aldosterone. And this is how we do it. This is how we do it. So basically, there's four different tests. I never do the salt suppression. I'm sorry, I never do the saline infusion because you need to admit the patients, or the fluorocortisone stimulation, or the capture pill challenge. They're very old-fashioned. So what I tell the patient is like, you're gonna eat McDonald's every day. That's actually gonna give you enough salt for 3 days, and you're gonna go to the lab on day 3. You're gonna make sure they're not hypokalemic, because remember, hypokalemia is a stimulus for more aldosterone. No, hyperkalemia is a stimulus for aldosterone release. So you need to correct the hypokalemia. That way you're not affecting the aldosterone secretion. And you start measuring the test with the 24-hour urine. And after you do the 24-hour urine collection, you have a diagnosis if it's greater than 12. That's actually how I do it. But you will have doctors disagreeing on how to do this test. I think the higher the aldosterone level, the more likely that you're dealing with the confirmatory with a positive confirmatory test. So that's why we do the 24-hour urine aldosterone after oral sodium loading. Okay, this is basically how I do it. You're gonna get the slide so you can review it at your convenience. Okay, so read the second question, please.
You intensify her BP meds and give KCl supplements, which is the salt suppression test. Potassium is 3.6, 24-hour urine, 1.2 grams, creatinine to 280 millimoles, sodium, 54 micrograms of aldosterone. You've just diagnosed PA. What are you going to do now? Order an adrenal CT scan, refer for adrenal vein sampling, or start spironolactone?
What are you gonna do? Well, the answer is always to get a CT, but you have to think about, like, if you have a very old patient, you may make an argument like, this person is not going to be a candidate for surgery. Why do I do a CT? Some doctors will make an argument that you always want to do a CT because if you have a mass, an adrenal mass, and if the mass is very large, the likelihood of being a malignant mass is pretty high. If it's greater than 5 centimeters, the higher, the more likely that you're dealing with a malignant mass. And that's the reason why we order an adrenal CT in all cases. But remember, on your boards, you never answer doing an adrenal imaging study unless you have biochemical evidence for both for Pheo and for primary hyperaldo. Okay? So now you know that the CT has like a 1 centimeter adenoma in the left and the right is normal. What do you do next?
I mean, are they a candidate for surgery?
Yeah, let's say this person is. What do you do? A 1 centimeter adenoma is almost always benign. There's no concerns about malignancy here.
Would you do the adrenal vein sampling then?
Yes, you do the adrenal vein sampling because if
you suspect something, so you want to check it. Yeah.
Absolutely, and these tests should always be done before you do surgery because you need to tell the patients 2 things. Number 1, if you get surgery, you may have 50% chance of getting your hypertension cured. You need to tell them this because one of my colleagues he was sharing with me that he never really disclosed that to the patient, and this lady was very upset because she went through all of this pain and nothing really happened with the hypertension. She probably had primary hypertension with superimposed secondary, primary hyperaldosteronism, but you need to tell them that. And also because you can have adrenal hyperplasia, and that may be where the aldosterone is coming from, and that 1 centimeter adenoma wasn't where the money was. And the only way you can rule it out is by doing a adrenal vein sampling. Who does adrenal vein sampling? Most interventional radiologists, before urologists were doing this, but yeah, this is interventional radiology. Okay. So these are actually studies showing that patients with primary aldosteronism, they have an equivalent average blood pressure if you do surgery or if you treat them with spironolactone. So you can make the argument, why would you want to do surgery? But if you have a young, otherwise healthy person, why not doing surgery? You know, if I get this problem, I'm probably gonna want to do surgery, get rid of taking a medication that may cause like impotence or gynecomastia or who knows, hyperkalemia, who knows what other side effects. But the what I'm talking about is like if your patient has multiple comorbidities or they're old, you can just jump and start treating and stop the story. Okay. So she would like to pursue surgery, so you do vein sampling. And these are studies showing that the disease can actually be bilateral. Can you do bilateral adrenalectomies? Can you remove both bilateral adrenal glands? No, that would be malpractice. It will kill the patient, will die from adrenal insufficiency right away. So that's why this is not a light decision. You need to have a lot of evidence that this is exactly what you want to do. So adrenal vein sampling confirmed unilateral disease on the left. They did a laparoscopic left adrenalectomies. Blood pressure is now well controlled and monotherapy with lisinopril 10. This is probably the more likely outcome, that the patients are going to require less medications, but if they get completely cured, it may happen, but don't create false expectations because your patients are going to be upset after going through all of this. Okay, so this is the algorithm. Possible PA, you do the screening test, which is the aldo over renin. Then you go to probable PA, and then you do the confirmatory test, which is the 24-hour. And then you do adrenal CT if there is, suspect of PA, but there is no cancer. Then you ask the patient, you want surgery, you don't want any surgery. If you don't want any surgery, you just give them spironolactone. If you desire surgery, you need to do adrenal vein sampling. If it's just unilateral, the excess of aldosterone is coming from one adrenal gland, you operate. If the excess of aldosterone is coming from both glands, forget about it. You can't do anything about it. Okay?
Can you remove one?
If you have aldosterone coming equally from both glands, you're not going to fix anything by doing just one. Yeah. That's what they recommend. You don't. In that case, you don't operate. You medically treat. Okay. Can you help me with the third case, please?
You referred a 71-year-old woman for resistant hypertension. She has spells consisting of headaches, palpitation, diaphoresis, and tremor, chronic pain on acetaminophen, and amitriptyline. Otherwise asymptomatic. Blood pressure 180/65, pulse 78, normal weight, unremarkable exam. Erberstratin, amlodipine, and atenolol. She's PCP performed a CT abdomen with contrast, which is normal, and fractionated plasma methanoephrines. Plasma norepinephrine is 1.2. Plasma methanoephrine is 0.22, which of the following statements true?
Okay. What do you think? So the plasma norepinephrine is mildly elevated. Is that Theo?
No. So it's elevated to B.
Yeah, that's correct. And the reason being is that the teaching point for you guys is that you can have a false positive in many settings, and for you to be able to comfortably call a Pheo, some textbook says 3-time elevation, some textbook says 5-time elevation on the upper level. In other words, that you need to have a lot of like biochemical evidence. So it's a rare condition. In adrenal, they're easy to find because the mass is I wouldn't call it pathognomonic, but if the radiologist is calling it a Pheo, you better believe it, because the mass is very regular shape, it's cystic, and radiologists are well trained to be able to recognize it. And make sure you don't ignore it, because there is a pre-biochemical phase. In other words, you may have the mass without the biochemical excess, but those patients eventually are going to end up developing the syndrome, the clinical syndrome. So make sure you understand what can give you a false positive test. So a lot of medications, TCAs, like tricyclic antidepressants, decongestant, amphetamines, and even withdrawal from clonidine, narcotics, alcohol can give you a mildly elevated, like this lady had a 1.2, that's nothing. So
I also assume since she's old that the likelihood of her actually having the field is very low.
it's very low. It's usually younger people. Yeah. But always recognize that. Okay? Okay. Alright. Help me with who's next? You are, no?
You're confronted by a single, 45-year-old woman who is presented for the first time after avoiding medical care for the last 10 years. Her BP in the office measured once is 151 over 36. Both of her parents have high blood pressure. You should gather more BP data.
Yeah.
Whether measuring diagnosis.
Yeah. So there's nothing wrong if the patient is mildly hypertensive. You want to get more data to make an accurate diagnosis of hypertension and to educate them on the ABCs. So make sure you don't enter medications right away on your boards. Help me with the second one, please.
So you set her up with an ambulatory blood pressure monitor. Her average 24-hour BP is 147 over 91 millimeters of mercury. Her serum chemistry, urinalysis, and serum creatinine are all normal. You should.
Would be B.
You guys agree?
Mm-hmm.
Yeah. Okay. Help me with the third one.
After eating a healthier diet, exercising more, and losing 10 pounds, she achieves her goal blood pressure. However, at her routine visit with you 2 years later, her blood pressure is again high, 150 over 95. Over the prior 2 months, she has had similar home BP readings, which she takes twice per week. She has maintained her healthy lifestyle. You should start at Tylenol, start hydrochlorothiazide, start chlorothalidone, start minoxidil. You start with the things you said aren't on there that for the options that you said for managing.
Oh yeah, it's there. You can start one or the other, but I have a preference, one over the other one.
Chlorothalidone?
Chlorothalidone is my preferred choice because it's longer acting and I have better therapeutic response. Chlorothalidone is a very old medication, like I think it was invented in the 1970s, but it's regaining more and more role in the hypertension management because it's longer acting than the thiazide. But you always have to have labs before and after. You always have to watch for the metabolic complications, and you never start a beta blocker as a solo therapy for hypertension. Beta blockers are very good for patients with like a lot of anxiety component in patients that actually have some sort of arrhythmias or some sort of like cardiac conditions, but you never prescribe it as a solo agent for management of hypertension. If you see a patient on a monotherapy with a beta blocker, that patient is not being adequately managed. And minoxidil is never first line. It's always last line because it's a medication that has side effects in a female. You know, if you're not, one of the things to assess compliance with minoxidil is just look at the facial hair. If you don't have facial hair, it's because you're not taking it. So it's a difficult medication to tolerate, and it can cause. I saw a patient died from a pericardial effusion and a cardiac tamponade from the use of this medicine. And it also it causes edema because it increases the renal sodium retention. So if I see a patient on minoxidil, it means that the other doctors already exhausted the other options, or the other doctors didn't do a good job. Because your job is to tell the patients, educate the patients that, for instance, amlodipine is a very safe medication. If you have a little bit of pedal edema, that's not a big deal. What you need to tell a patient is reassure them, tell them, you know what, if it doesn't bother you, it doesn't bother me. And the reason is because there's so many options that I have. And if I start like eliminating those options, the next thing I know, you're gonna be on clonidine, alpha-methyl-dopa, minoxidil, and a lot of these medications are not first line. They should never be first line. So amlodipine, the take-home message is that it's a very safe medication, and you always should tell the patients to have low sodium because that helps. If they have a little bit of swelling, just tell them to have less, to drink less fluid and to eat less sodium. To wear compression stockings, that's another thing. Elevate legs. So, and you reassure them because most patients they want to come off because they feel that's a dangerous side effect, and it isn't. So make sure you guys cover that with your patients. And yeah, minoxidil is never first line. So that's the teaching point. So there are some issues that are important for you guys to know in clinical practice, and is the management of hypertension in dialysis patients. Have you guys seen any dialysis patients here at Dr. Ben-Zur's office? Okay, so you may encounter these patients. So they're challenging because they're very volume dependent, and dialysis is always the correct answer when you're confronted with the hypertensive patient with dialysis. And you guys know about if the dialysis patients make urine or they don't make any urine? You guys know? They still urinate or they don't urinate? What do you guys think?
Very little.
So most patients, after some time on dialysis, like months to years, they stop urinating. Most patients. So when you interview a dialysis patient, you always need to ask them, are you still making urine? And this is a very important question for two reasons. Number one, patients that still urinate, they enjoy from better quality of life. There's so much fluid that you can drink if you're totally dialysis dependent, number one. And number two, having a urine output correlates with better survival. So it's not the dose of dialysis what's gonna keep you alive. It's actually your ability to preserve residual kidney function. The problem is that if you have diabetic renal disease, the fact that you start on dialysis is just not going to stop the damage. The damage will continue to progress until the whole kidney is completely gone. So, and a very important implication is that if your patient is still urinates, you should make every possible effort to preserve that residual kidney function for the reasons that I explained to you. So if you're a primary care doctor, you do not prescribe an NSAID because you're going to think like, oh, this guy's already on dialysis, who cares? Let me give you a little bit of naproxen. Wrong. You never do that. Especially NSAIDs are a bad medication in a dialysis patient because they can cause severe hypertension, they can cause GI bleeds, and they can kill the residual kidney function. So by the same token, if you need a contrast study, like you need to ask yourself, do I really need to do this? Do I really need to give contrast to this patient? If you give them contrast, you need to tell them, it's possible that you may develop it may be harmful to your residual kidney function. Sometimes it is what it is. I have patients coming in because they have a heart attack and they call me, can I give them contrast? Of course, your answer is going to always say yes, go for it. Why? Because the benefit outweighs the risk. And what research shows is that dialysis patients and advanced kidney disease patients, they get underdiagnosed and undertreated heart disease because of this concern of like not harming the kidneys. But that's when your clinical judgment, plays a role. If your patient is requiring contrast because you need to stage like a cancer and there's no other way of doing it, it is what it is. But if there's something that you can do, let's say chest pain, and you can do, instead of doing a CT angiogram, you can do a VQ scan to rule out PE, that's probably what you should do. Or do I really need contrast? You can tell the radiologist, hey, can you diagnose this diverticulitis without IV contrast? Most radiologists are going to say, yeah, absolutely. Let's do it without contrast. So I want you guys to always develop that ability to ask your dialysis patients, do you still urinate? Another thing that I want you to know is that every dialysis patient, they know what the dry weight is, unless they're completely clueless or they're demented. So they know what the dry weight is. You guys know what the dry weight means? in dialysis patient?
Weight after dialysis.
How much do you weigh after dialysis, or the weight that we're targeting? And the reason is that the dialysis patients, they gain, there's a very clear distinction between your solid weight, which is your bones, your meat, your fat, your muscles, and your water weight. So dialysis patients, when they have limited urine output, they gain water weight in between treatments. But they may also gain solid weight, or they may lose solid weight, depending on what's happening. If they're not eating or they're overeating, you can have both. So how do we know what's happening? So we can tell based on the blood pressure. And the easy way to remember this is, if blood pressure is high, the solid weight or the dry weight needs to go down. And the opposite, if the blood pressure is too low, that means that the nephrologists or the nerves, they need to go up on the solid weight. Does it make sense what I'm saying, guys? You guys understand what I'm talking about? It's a little confusing because the patient is like, what do you mean? So we make those decisions based on the patient's blood pressure. Having said that, if a patient is very hypertensive, that means that I need to challenge that weight. I need to set a new dry weight, and in clinical practice, we go down by 0.5 kilograms. We don't overdo it, because when you overdo it, dialysis patients feel terrible. They have muscle cramps, they have dizziness, the redistribution of fluids usually happens when they go home, and they feel terrible. And that's one of the reasons why, if you ask a dialysis patient, do you have any side effects from dialysis? Most patients are going to tell you, like, yeah, man, I'm so exhausted after dialysis, I can't even function the next day. And this is true. That's why I personally like more dialysis at home, or peritoneal dialysis, because these patients, the removal of water and solute happens in a very slow fashion. It's a continuous renal replacement modality, and peritoneal dialysis patients don't have these severe shifts in fluids. Like most patients that are on dialysis, they have a hard time adhering to the fluid restriction, and part of it is because a lot of the patients that they end up on dialysis are the ones that are non-compliant. So don't think that they were non-compliant when they had diabetes and they're out of the blue, they're going to become compliant now that they're dialysis dependent. The compliance actually gets worse because now they have so many medical problems and they don't feel well that they don't care. So I had a patient, typically we tell the patient, this is another question that you need to ask your dialysis patients. You need to ask them, how much is your dry weight? Do you still urinate? And how many kilograms do you gain in between your treatments? So you guys know how many kilograms they should gain? Or they should not exceed how many kilograms? 1 kilogram per day. So dialysis is usually done either Monday, Wednesdays, and Fridays, or Tuesdays, Thursdays, and Saturdays. So there is a couple of days that are 2 days, and on the weekend there's 3 days. So if it's during the week, they should not gain more than 2 kilograms. I'm talking about compliant patients. That's not the case for most patients. Compliant patients should not gain more than 2 kilograms in between treatments, and no more than 3 kilograms on the weekends. I had a lady, the lady was gaining 9 and 10 kilograms in between the treatments. And she ended up dying from cardiovascular complications, because that causes a lot of myocardial stunning, and you're chronically volume overloaded, and your risk for cardiovascular mortality, it's exceedingly high when you don't pay attention to your fluid. So just imagine how hard it is to be a dialysis patient, that you're limited in sodium, limited in phosphorus, limited in potassium, and limited in fluid. And like I was describing to you guys, these patients, they're all thirsty. They feel like they want to drink water all the time and they cannot pee. So it's not easy. But your job, if you have a hypertensive patient on dialysis, is to assess those questions, and you should contact the nephrologist that's taking care of the patient, because that way you guys can actually request that the weight is brought down. That's the first thing that we do. And the second thing that we do is make sure that the weight is brought down. And the third thing that we do is we make sure that the weight is brought down to correct the hypertension. If that fails because either the patient refuses to get a lower weight because they don't feel well, they develop cramps, that's when you start thinking about 2 things. You start either thinking about increasing the dialysis time. More dialysis represents more solute removal. but most patients they're not gonna go for that because they're already sick of it. Most patients receive 4 hours of dialysis 3 times a week. If I imagine if I ask you to be sitting there for 4 hours getting your blood clean, it's pretty painful, right? So most patients are gonna refuse that, or that's when you start playing with medications. But it doesn't matter if it's a dialysis patient or a non-dialysis patient. Your job as a good doctor is to always cover the ABCs: activity, weight, dietary sodium intake. Okay? And then that's when you start basically. So the way I do is basically dietary and sodium restriction, prescribe at least 4 hours, probing the dry weight or challenging the dry weight. And there's a modality when you get dialysis at night. Those patients have better blood pressure control. They dialyze the whole night, hemodialysis. That's called nocturnal hemodialysis. And the most effective treatment is transplanting your patients. That's actually the most effective treatment for hypertension in the dialysis population. Okay. Guys have questions?
Wait, so can you go over the ABCs again?
ABCs are basically dietary sodium restriction. You need to ask the questions that I told you. You don't ask your patients, do you add extra solids? No. How many times do you eat out? Right?
Mm-hmm.
How many do you have TV dinners? Do you have processed foods? Deli. Those are associated with high sodium deli products. Or olives, capers, soy sauce, fish sauce. In the Asian patients that I have a lady who's Thai. This lady, she can't give up the fish sauce, and her blood pressure is always high. And it's very sad because I know that if she gets rid of it, I'm gonna be able to control her, but that's not the case. So weight reduction and recommending increased physical activity. And you go over the medications. Remember, NSAIDs, OCPs, decongestants, Sudafed, and you ask about the illicits like excessive alcohol intake, cocaine, amphetamines. That stuff is definitely associated. And you review the prescription medications for OCPs, calcineurin inhibitors, EPO, VEGF inhibitors, any of those medications. What else? Any questions, guys?
Sorry.
Oh, go ahead.
No, this is a dumb question. But you say when you elevate your legs, is it supposed to be above the heart, right?
What do you mean when you for edema?
You have lower extremity edema?
Not necessarily. I mean, that's more effective, but just laying down, elevating your legs, just a little bit of your heart level. Like let's say you put a pillow.
What about when you're sitting? Just kind of put
You can do that. But if you ask the patient with edema, they all get better in the evening when they wake up, and as the day progresses, they start getting the worst. So if you have a calcium channel blocker, oh, by the way, I forgot to mention, you may get a board question when they actually have gingival hyperplasia. That's a side effect from calcium channel blockers. So make sure you don't get it wrong. Gingival hyperplasia. So, and it's dose dependent, and sometimes it's not reversible when you've had it for a long time. When you stop it on time, they can go away. Sometimes you cannot get rid of it. That's probably an indication to switch the calcium channel blocker to something else. But my job to you guys is to teach your patients that we always want to go with the first choice, first line agents, and you always want to maximize that agent, and you always want to try to wait until you add another agent before you maximize it. And if your patient is already on, let's say, an ACE inhibitor, thiazide diuretic, and a calcium channel blocker, and they're still hypertensive, the next drug is, we learned today, the Aspirin trial and the Simplicity trial. Which one? Spironolactone. Yeah. Unless they have severe kidney disease or severe hyperkalemia. Okay. We have many different drugs. We didn't cover drugs. If you want, we can talk about drugs, like how they work. You know, which category antihypertensives you guys remember? So we talk about the thiazides. Thiazides are the first line: severe hyponatremia, hypokalemia, hyperuricemia, hyperglycemia. It can cause gout. You need labs before and after. They work by inhibiting they work at the cortical collecting duct, increasing sodium excretion. They're very effective and always first line unless you have advanced kidney disease. We don't use them when the GFR is less than 30. Then we have other diuretics. Which other diuretics do you guys remember? We talk about loop diuretics. They work in the loop of Henle. We have the loop diuretics. Usually they block the sodium chloride transporter in the loop of Henle. Very effective for water and sodium excretion, not so much for hypertension. I told you guys that we never use it as a solo agent for hypertension management. So then we have the potassium sparing diuretics. They work at the distal tubule, most of them. So we have several of them. Do you guys remember some of them? The potassium sparing diuretics. So we talk about spironolactone. It works different than the other ones because spironolactone directly binds the aldosterone receptor, and that's how it works. But which other
Something with
eplerenone? Yeah, it works differently, but it's similar to spironolactone, but it doesn't inhibit directly the receptor. What else do you guys know? Triamterene. Triamterene. It works pretty good. It's a potassium sparing diuretic. It can cause hyperkalemia like all of the other ones, and it can also cause kidney stones. That's one of the side effects. Triamterene stones. It actually gets absorbed, filtered, and when you take it for some time, you can actually start secreting triamterene stones. What other potassium sparing diuretic you guys know? Have you guys heard about amiloride? Amiloride is a very powerful antihypertensive. It actually works by blocking the epithelial sodium channel in the distal tubule, the ENaC channel, and is a drug of choice for a condition called it's not Gordon syndrome. It's gonna come to me. It's a genetic syndrome that is a gain of function mutation of the ENaC channel. Little syndrome. So that's the treatment of choice of little syndrome. You just give them a little bit of amiloride, and if it is truly little syndrome, that's actually a good way of before you do the very expensive genetic testing, just give them a little bit of the amiloride, and if it cures the hypertension, you get the diagnosis. And then we have what other diuretics do you guys remember?